What's up, everyone? Welcome to the Pinnacle Performance Podcast. Today, I have Zach Cupples for you guys here today. I know I've been looking forward to this one in particular for a very long time because Zach talks a lot about the principles that I personally prioritize and have been studying for quite some time. So, Zach, thank you so much for being here, man.
Connor, it is an honor, privilege, pleasure. I'm juiced up as all hell to be chatting with you today.
Thank you, man. Thank you. Yeah, this is going to be a fun one. I've got some great questions for you. And just for those who might not have heard of you before, could you give some background about yourself and kind of what you do?
Sure. So my name is Zach Cupples. I'm a physical therapist, strength conditioning coach, and a blogger. I work out of two places. So the first place that I work is the internet. I'm on zachcupples.com, where I offer a lot of remote consultations, training, mentoring, and I teach my seminar, Human Matrix, which is basically applying a lot of the concepts that we will talk about today. And then the other hat that I wear, which when you're bald like me, you got to wear hats, otherwise you get burned, is Elevate Sports Performance and Healthcare in beautiful, sexy Las Vegas, Nevada. I am a physical therapist, trainer, and the director of education there. I've been there since March. It's an amazing place. If you're in Vegas at any point in time, come stop and see me. And I've been a physical therapist for, getting old now, 8 years, worked in a wide variety of settings. I've done, what have I all done? I've done NBA, I've done workers' compensation, persistent pain, I've done travel physical therapy, kind of been everywhere, seen a lot of different things, and I've done some training as well. So, being fortunate to be able to work with a wide variety of people has given me a unique set of skills and has really helped shape my model to see if I could reach these people in the simplest and most effective manner possible. And I'd say that's what drives me is the stuff in our field, and even that outside of our field, can be incredibly complex because it's the human body. So if we can devise useful heuristics to follow, I think that's going to help us achieve better outcomes with the supreme clientele that we work with. And I'm not, you kind of gas me up a little bit. I'm not that smart, so I have to really dumb things down in order to apply it well. And people find that useful. So I try to do that for the people who follow me, the fan, as we might say.
Well, I mean, I think in order to dumb it down to that degree, you have to know the material pretty well, and you have to understand what's going on at so many different structures. And that's something I try to do myself, is like try to make it simple while still respecting the complexity of what we do. So in terms of Human Matrix, I've never been. It's definitely something I have high on my priority list of just courses to attend. So in terms of that model, I know you've been doing it for how many years now?
This would be if the apocalypse didn't put things to a halt. I did one in January, though, so I guess this counts. This would be year 2 or 3. I'm trying to think when I did my first one. I think my first one was 2018. So this would be 2 years of it.
Okay. So it's still relatively fresh. And I'm sure we're constantly evolving. So how have you seen Human Matrix and just your own personal perspective and how you're looking at the human body? How is that evolving and where is it now?
Oh, God. Well, I should send an apology letter to all previous Human Matrix attendees because I think it's interesting because I think it's one thing to teach on a blog and you don't get the immediate feedback of, are people getting this? Is this useful? Is it not? Versus the way it is in person. And the feedback that I've gotten has been consistently that this has made things easier. Great. But then I also realize that I am losing some people there, and I want to try to lose as few people as possible. And another issue that I've seen as I have started Human Matrix up until now, and I notice this mostly with a lot of the mentees who I work with, is they get the didactic side of things, especially, I mean, there's so much information out there to consume, and it's free. I mean, there's nothing, the things that I'm talking about are not new. It's the amalgamation of a lot of things that I've learned from folks like Bill Hartman or reading of my own. But what I'm seeing is there's a disconnect between the theoretical and the application. And there's a lot of people out there who I think they're not getting the results that they desire or that I talk about because there's a deficit in the ability to coach some of that stuff. So where I'm at right now and how that's shifted from early iterations of Human Matrix, because I'm going to be putting out 7.0 in August. I started with 1.0, is I'm trying to make the explanations as simple and jargon-free as possible, one, while also letting people understand that this is how I'm drawing from these conclusions. And because of that simplicity, I'm also trying to increase the amount of practical application that we have within the seminar. Like I want to make sure I can give time to the attendees so they can practice the stuff that we're talking about, so they can get real-time feedback from myself on how to coach these things. Because if you're not getting the results, it's probably not a knowledge deficit, and it's your ability to take that knowledge and apply it to the person in front of you. And that's where I'm going to try to be shifting my material in Human Matrix, is to be able to bridge that gap so you can apply this stuff in as simple a manner as possible.
Yeah, naturally the things you're talking about are so complex. And I know that when I watch your YouTube videos, there's very few times I have to stop it and rewind and go back, which I think is a good sign. And it speaks volumes to how you can explain it. So I think you do a good job of breaking it down, but it's to a certain point of like, how much can you break it down while still respecting the complexity of it? You know, that's something I'm always trying to do. And that's a process I'm learning right now, is sometimes I will say something and then I'll get a comment, or I'll realize later on, like, oh man, like that just wasn't the whole picture. You know what I mean?
Yeah, it's definitely really challenging. And I think it also depends on who you're talking to, because there's always going to be people who get it and want that layer deeper. But then there's going to be a lot of people, and this would be the bulk of the industry, who need the simplest explanation possible, because a lot of this stuff is new, foreign, and it's not taught anywhere else. Mm-hmm. And you factor that into, we're not, like in our schooling, if you're a clinician like me or you're a coach, we're not taught how to educate other people. Like that's a whole different field, teachers. So it's a very interesting dynamic that we have in our industry right now. And, you know, I'm still getting better at teaching, and there's still a lot that I have to learn, but yeah, I'm with you, man. It's really hard to take what's in your brain. Well, you know, take stuff, put it into your brain, and then put it out to other people in a manner that they understand. And that's really what I'm trying to do with all my stuff.
Mm-hmm. Selfishly, I know, like when I go and tell someone or teach someone how to do something, that helps me learn it even better. Because, you know, if I don't know, they're definitely not going to know. I can't be full of crap when I talk to them. So I got to really dig down and understand these things. So when it comes to your model and how you approach addressing the human body, I know you tend to be more exercise based, like you kind of like gravitate towards that end of the spectrum, as opposed to giving someone, you know, 5 breaths on a 90-90 hip lift, for example. What's your kind of approach with that? Like, what makes you want to gravitate towards exercise? And what if you have someone where it's like, okay, well, this person doesn't really want to exercise that much, they just want to feel better?
Great question. Well, so I think there's a little bit of a bias in terms of the people who just want to feel better. I don't get as many of those, at least online. And the reason why is because they know what they're going to get with Big Z. They know what I preach about and all of this. So when you put yourself out there as this type of person, you're going to attract people who want that type of person. It's a little bit different in person. But the way I educate my people is, well, first off, why do I use exercise as opposed to manual interventions? And I do use manual, don't get me wrong, but the way I think of it is twofold. One, in order for you to elicit a lasting change, you have to learn something different. So for example, I see you got a keyboard back there. Yes, you know, sir. I can play the key. Well, I would play it poorly, of course, unless, I'm making hip hop beats, and I might get a little fire.
There we go.
But I can, you can listen to me play until you're blue in the face, right? But that doesn't mean that that's going to make you better at playing your keyboard. You eventually got to put your hands on the keys. Same thing when it comes to movement, repatterning, and motor learning. And that's where I think manual therapy isn't always, well, it's useful, but if you can teach someone to reproduce what you're trying to achieve, it's going to be much more effective. And it's going to increase autonomy and give them some ownership. Mm-hmm. Because the last thing I ever want is to have someone be dependent on me. And I always tell this to my clients. I say, look, I want to make sure you can do this on your own because you can't take me with you unless you pay me a lot of money. And no one has ever asked me how much, darn it, because I mean, I totally would, if we had to do the 24-hour thing.
There's always a number.
But there is. Everyone's got a number. So I think people understand that. And also, too, I'll joke as well, and I'll say, the longer you work with me, the worse the jokes get. Like, I throw my best material out in the beginning, and then it just goes downhill from there. But the fact of the matter is it's to instill independence in my clients, and I think it works better. Now, when is a manual intervention useful? I think a manual intervention is useful when that person can't reproduce what you want them to reproduce. So, for example, let's just say, my favorite example is, let's say I have a loss of elbow extension because I got these big old biceps right here.
They're in the way.
And they are huge. So if my bicep muscle is, well, for the sake of argument, let's just say it's short or concentrated, whatever terminology you want to use, you have a limitation in elbow extension. And let's just say I can't, within my own body, do something to get the bicep to chill. I could most certainly apply a manual intervention to recreate that. And maybe that triggers something in my brain to say, oh, okay, this is what this feels like. Or then I reinforce it with an exercise. I'm all about that. I F's with that, you might say. I don't know if I can swear on your podcast.
Oh, feel free.
Okay, good. I don't swear much on mine, though, so I don't know if I should swear on yours, but go ahead.
This is explicit on iTunes, so watch out. So that's good to know. And that's something I've really, I started off in a corrective background myself, and I realized that correctives are boring. They're just like straight up not very engaging. Like, no one wakes up in the morning and goes, I can't wait to do my adductor pullbacks or my 90-90 hip lifts. No one really does that. Maybe they do. Maybe there's those crazy.
You'd be surprised who I attract. Like some of my clients, it's like, yeah. They do exist.
What you said about attracting people to you that are similar, I think that's an interesting point. I haven't considered that before. And I think a lot of my clients, especially like the coaches who want to like learn this material, they're obviously going to be younger because that's someone that's like my market, right? So I think that's cool. And I haven't really considered that before, but also with clients, I do see that. And I think that's why it's good to have a lot of people like you out there, like me out there, different personality types, and you attract different clients. So one thing I wanted to ask you, and something that I see is a big point of confusion. I see it in Q&As a lot of the times. I see it really whenever I'm talking to people about these types of models, is when it comes to compensations, the compensatory patterns. First of all, we see humans, and I think there's like this idea of a wide ISA and narrow ISA, and all these different patterns. And you're like, great. Okay. So they want to like pigeonhole someone in that category, where in reality, it's like this spectrum, and there's compensations. In my experience, at least, I very rarely see someone that's, a perfect blank, and there tends to be compensation. So how deep in compensatory patterns do you find most people generally are? Is it, do a lot of people tend to have just secondary? Is there tertiary? Like, how deep do you, I know that's a broad general question, but just generally speaking, where do you tend to see people on that spectrum?
Well, I don't think it has to be crazy. The way I think of it is, so you have your infrasternal angle is merely measuring what your structure is. And based on how that structure interacts with, is governed by the laws of physics, there's going to be certain predictable compensations that you should see. And then anything that goes beyond the predictable compensations would be something more secondary. And for simplification measures, I break it down into literally, you have two options, right? You're either going to be restricted in flexion, abduction, external rotation, or you're going to be restricted in extension, adduction, and internal rotation-based measures. Did I say that right? Yeah. ER, IR. Yeah. Okay. So flexion, abduction, ER, extension, adduction, IR. If I screwed that up, I don't think I did. So certain infrasternal angle presentations are going to be more predisposed to being restricted in one versus the other. right? So for example, and we can get into the nitty gritty if we need to, but generally a wide infrasternal angle presentation is going to be more restricted in flexion, abduction, and external rotation based measures, or at least they should. If they have any restrictions on the other side, extension, adduction, IR, you know that is the more superficial compensation, and it has to do with that person's structure. So, and then for a narrow, it would be the opposite. A narrow should be limited in extension, adduction, IR. If they have a flexion, abduction, ER limitation, that is a more superficial restriction. So the way I approach it is I make sure they can stack, which for those who don't know what a stack is posterior pelvic tilt, get a full exhalation so the two diaphragms can be relatively aligned atop of each other. Yeah, the alignment, people are going to come after me. It's like just, I don't know if that's really what's going on, but at least that's how I think of it. And that's not how I educate my people. So
it's a good way to think of it.
Yeah. It's just the biomechanical influence. So it's like, get that first, because that's going to give you the potential to have movement in a variety of positions. Is going to restore normal, with the scare quotes, respiratory mechanics. And then you would address the more superficial layers before the deeper layers. So for a wide, you would address extension, adduction, IR restrictions first, because that's the more superficial restriction. And then you would go after the flexion, abduction, ER, because that's based off of the first structural compensation that you would see. And that's really like what I've boiled it down to, is as simple as it can possibly be until I learn more. And that's really just how I approach it. And so then from an exercise or manual intervention selection, you just pick activities that put them in the positions that they struggle to get into with, and you make them suffer there in a nice, friendly way. And a lot of times that leads to improvements. And if it doesn't, then either you didn't coach it well enough, you picked the wrong move and that person can't execute it, or you got something else going on that's blocking you. And that could be a wide variety of things.
I just wanted to say that I literally cannot go without thinking of, if you can't stack, don't talk to Zach. I can't go thinking about that without hearing the word stack. It's impossible. So you've done a great job of bearing that in my brain. It's awesome though.
Well, that's good. That's good. I hope like when you're working with clients, you just, you see this, you have like this bald headed person hovering over you, just saying, if you can't stack. Yeah.
It's great. It's great. I'm always laughing when I watch your videos, but anyway, I was hoping you could go into, if you don't mind, the nitty gritty of these compensations. So let's talk about the pelvis first. And I think this is where it can get a little confusing for people. So I guess we'll try and keep it simple. But what do you see as the secondary compensation? So we've got, let's say, narrow, and then they have that secondary compensation. What is the tertiary compensation? What tends to happen in that third sort of predictable process? And I know obviously it's not always going to be this way, but what do you generally see?
Well, let me ask you this, Connor. Are you going to have the video available or no?
Yes.
Oh, you will? Well, give me a second. Let me grab my grandson.
Go ahead. Your grandson.
My grandson, because he has the shorter legs.
There we go.
So, whereas my son, he's a little bit taller.
That's right? Awesome.
Yeah. So, narrow versus wide infrasternal angle. Based on the shape of that person's ventral cavity. A ventral cavity is the thorax, abdomen, and pelvis in total. All right. That is going to influence the degree of dissension that happens with the diaphragm. Okay. And, there's some physics stuff that we could get into, but it's, just for all our intents and purposes today, if you want to learn the physics, listen to the debrief or whatever. But the narrow infrasternal angle has a further descended diaphragm than a wide infrasternal angle, based on the physics of their body. So if the diaphragm is more descended with the narrow, that means the viscera, the guts, and the goods are going to be pushed further downward. Now, your body is going to try and do things to catch that viscera, all right? And for a narrow, what's going to happen is the sacrum, which is your big bone right here, is going to counternutate, which is tipping backwards for those of you who are listening in. When that happens, the innominates, or your pelvic bones, they're going to rotate anteriorly and spread apart. This increases the surface area of the top part of the pelvis. Now, there's only about 2 degrees of motion at the SI joint, unless you got a fusion, don't get it. There's 55 degrees of flexion in the lumbosacral complex. So because 55 is more than 2, the pelvis is going to tilt relatively posteriorly when I counternutate. And this is with a narrow infrasternal angle, all right? And that's to catch the downwardly displaced viscera. In comparison with a wide, the viscera is not going to be as descended. So counternutation is not necessary. Instead, what's going to happen is nutation, where the sacrum tips forward, the innominates rotate posteriorly. This decreases the surface area of the pelvic inlet, the top part of the pelvis, and that's going to tilt this puppy forward. You're, in standing, there's a cool article, 1955 by Weisel, which is like the sacroiliac joint mechanics. It's really dope. They took x-rays of a bunch of people in different positions and measured, is the pelvis nutated, counter-nutated, or the sacrum? And standing, you're nutating. So less of a downward pressure. So we have to look at that. That's inherent structure. You can't change that, right? Unless you get a, I don't know, total ribcage replacement or something.
That'd be interesting.
And yeah, right. Which, yeah, good luck with that. So because of that, you have this inherent bias towards these particular movements. And if you can't manage that bias, there's going to be compensatory measures. All right. So by managing the bias, what I mean by that is you fall flat on your face. Gravity wins. So if the 9.8 meters per second, if you're narrow infrasternal angle and you got 9.8 meters per second pushing downward, and the sacrum counternutates and it tips backward. Connor, if this tips backward with reckless abandon, where would I go? Where would my spine go? Where would it fall?
Back.
It would fall backwards. So you ought not do that. Your first layer of compensation then is to upright yourself so you don't fall, which means you would concentrically bias stuff on the front side of your body to pull you upright.
Is that stuff going to vary from person to person, or is it going to be fairly predictable?
It's going to vary from person to person because of other layers of compensation.
I see.
Because you almost have it's like this game of Pong.
Mm-hmm.
Because your first layer of compensation as a narrow should be stuff on the front becomes concentric. And that's where the extension, adduction, and internal rotation restrictions happen, is because if you concentric bias stuff on the front, and by stuff, I mean on the ventral cavity, you ought to be limited in extension, adduction, IR. But now let's say in theory, and I doubt it happens this way, but if that leads to an overcorrection and you now start to fall forward, well, then you're going to concentrically bias stuff on the back to upright you again. And then you have this back and forth thing, right? And it usually goes higher up. And I think the reason why you might see greater compensations the more north you get has to go with the fact that there's more gas present in the lungs and the upper airway. Gas is the only compressible thing, or the compressible thing in matter, whereas liquid and solids, not so much.
Never thought of it.
Yeah. So it's like, why does everyone have a stiff thorax? And why are our upper airways jacked up? Well, gas is compressible. Liquid, not so much, right? Unless you have high temperatures. So because of that, the layers of compensation would likely be greater the more upstairs you go. But from a simplification standpoint, it's like in that case, if I concentric stuff on the back, which would limit flexion, abduction, ER, you go after that first. And then you go after the extension, adduction, IR measures when that's cleaned up. And that's something throughout the body. That's the thing. So that's where having a comprehensive assessment is useful if your goal is to maximize movement options. Mm-hmm. Now, from a practical standpoint, if you're a trainer, what I think would be useful is for that person, you should be able to get them to squat, because that's going to be an expression of maximizing flexion abduction ER. And then a hinge from a lower body perspective would be your extension adduction IR thing.
I see.
Right.
So really it's just this game of back and forth, falling forward, falling backwards, and then it just works itself up the chain until you have X amount of layers. So how do you tell, like, how do you look at someone? And I'm sure experience plays a role in this as well. You get someone on the table and you're like, okay, you appear to be in a fourth layer of compensate. I don't even know if that's something you care about, but how do you determine how deep someone is within a certain compensatory pattern based on your testing?
Well, actually, it's a 3-step process. Like, I don't worry about like quaternary compensations. It's okay. What's your structure? This is what you should be limited in. If you are limited in other things beyond that, I address those primary limitations first.
I see.
That's it. And that's it. And having switched to that frame of mind has made exercise prescription that much simpler. Yeah. So I like, really, that's it. And it's a matter of just making sure I check all of those boxes, and then I move on to the next thing. Where things can get challenging, if anything, is if you have someone who does have a lot of, who is limited in multiple directions. That's a little bit of a tougher person, but I still think the process remains the same. So it's find the structure, know what limitation they should have. Anything beyond that means that you need to address the stuff that's beyond that first, and then work your way backwards. And for a narrow, it's they should have extension adduction IR limitations if they're compensatory. If they have flexion abduction ER limitations, that gets tackled first. And then it's flip-flop for a wide. Wide should be limited in flexion abduction ER, but if they have an extension adduction IR restriction of any kind, you tackle those first. And if you do those things, you ought to be in business. At least from a theoretical perspective. But now you got to be able to coach people to get into that. And that's where the rubber meets the road, so to speak.
That makes perfect sense. So what if you ever had someone where it's like you don't know where they started because they have so many compensations that it's hard to tell where they even began? How often do you run into those people, if at all?
Where it gets confusing, two things. If you're assessing people remotely, I found that the margin of error for determining the infrasternal angle is a little bit more than someone who's not. And even myself, and like I've ran into the situation where I measured someone a certain way remotely, and then I met them in person. And of course, when I meet anyone, it's like, hi, lift your shirt up so I can test your infrasternal angle now. But when I measure them in person, it's like, oh, well, you still got better, right? And that's the thing with this. It's like, even if you're not perfect, if you just coach things well, you're not going to kill anyone by messing up the ISA. But where I think it becomes confusing is when you have people in the middle ground, like 90 to 110 degrees. And usually those people are restricted in more directions. And that's why the angles are in that middle zone. So, and in my eyes, I'm using a little bit of clinical experience to know who works for what. But, if I'm 100 and above, that's usually more wide-based stuff. If I'm 100 and below, that's more narrow-based stuff. Now, if you're 100, just pick one and see what works. So that's really like how I operate. It's still very systematic. Like, I've tried to not have any outs of where I don't know where someone would be categorized or someone who doesn't fit. Because it's simply, you break them up into one of two structures. You can have restrictions layered upon that. And, because the only movements available are those 6 that I talked about, you're really not going to miss anyone. The only time I would say when it might get confusing is if you got someone who's more floppy, where they are, someone who's hypermobile.
Oh, I see.
But even them, if you're strict with your testing, you can still find compensation somewhere. Like I've had 2 girls like this recently where they were narrow. Well, and when you have them breathe, you don't notice, because you should have outward and upward movement during inhalation and downward and inward movement during exhalation. You don't see that. You can't cheat your bones and your ribcage structure. But then a lot of times those people will be more restricted up in the cervical cranial region. And that's always a way that you can check to see if there's, some markers of restriction. But even then, it's like you're still tackling the same things. And maybe they look beautiful on the table, but then when you get them up to do something in the weight room or whatever event you have them do, they look terrible. So then that becomes your testing. And the movement principles are still the same. So even if you don't have access to a table and you're just coaching good movement, well, if you look at movement through a bit of a different lens, namely breaking it up into these two classification systems, I think you can still make some good decisions for people and then program accordingly.
Yeah, that's well said. And the floppy people, the people that are hypermobile, those have always been the people I struggle with the most, because I don't know, I guess it goes back to that classic saying of it's easier to give someone more mobility than it is to take it away. What are some just like basic strategies you have to get those people to like calm down and be able to control the range of motion? Is there are you going to go after more compression based stuff? Like what's your exercise selection going to look like for someone like that?
Well, this is where I think manual therapy would potentially be a bit more useful, because if I have these, extensive eccentric biases within the body, namely they're super flexible, it's going to be harder for them to generate tension. So using manual therapy can be very useful to get them in positions that they might not be able to generate because of inability to contract the muscles the way we want them to go. But then it's just, but once you have the stack, there's not much difference that I see when coaching them. It's just a matter of finding positions and exercise that they don't express the hypermobility and maintain the stacked position. So, doing a lot of isometric holds in the mid-range, especially if it's like a squat. Maybe not using quadruped because, if they have crazy amounts of elbow hyperextension, then you're not driving the changes you want. Because, if I'm in quadruped, I should be in humeral flexion. But if you extend, do elbow hyperextension, well, then you're going to be moving more towards humeral extension. So then maybe it's like using something like quadruped on elbows as an example. So it comes back to good coaching, is like knowing what you need to see and then just choosing exercises that allow them to express movement with integrity that doesn't fall into these compensatory strategies, which in their cases is hypermobility. I also think another thing that's at least useful from a theoretical perspective is using blood flow restriction.
Interesting.
And the reason why that is because you can get greater concentric bias with less of a 1RM or less percentage of your 1 rep max.
Yeah.
So you don't fatigue these people out as much, which is also nice.
It's a sneaky good trick right there. I like that. Do you care about how much emphasis do you put on the idea of like a pathological shoulder and pelvis? Is that going to change? And to define that, let's say that's ligament laxity. Let's say someone has stretched out their ligaments beyond the norm for them for whatever reason. How much does that play into your approach?
Not as much as I used to think. I think, I think like focusing solely on ligaments is a misnomer. If someone has hypermobility, it's not just the ligaments, it's all the tissues. The joint capsule has had to change. You've had to have a change in the resting tension of musculature. There's likely fascial changes, cutaneous changes, and nerve changes. So I'm not one to hang my hat on one specific tissue. And the other thing too is if we can change someone's bias and tension very quickly, then is it really a laxity of tissues that we're seeing? Like, for example, I was on this kick for a while where I would check Bill, when I took the intensive, Bill showed us a way to check shoulder flexion that appreciates the glide of the humerus. So if you put your thumb in someone's armpit, which asks for permission first, especially if someone's ticklish, Sometimes you can feel the humeral head glide into your hand.
Yeah.
Yeah. But then here's a cool thing, right? We do some interventions and that would actually go away. And I think I have this kid. Oh my God. I remember this kid who I had. It was when I was my last job in wonderful Page, America. That's just Page, Arizona, for those who don't know. This kid would have this crazy subluxation anytime he moved his shoulder. So like he would lift his arm into abduction. You'd see this visible as he moved. And I would check horizontal abduction and I would palpate the front of the shoulder. And, you know, normally if you palpate the front of the shoulder, you're going to feel some tissue and maybe a little bit of bone.
Mm-hmm.
Nothing. Wow. It was just like this abyss. It was like I was putting my fingers into the abyss. And then I would take him into horizontal abduction and he would have this violent anterior glide that would go, boom, and then you'd feel the bone. And I was like, whoa, does this guy have some laxity? Well, guess what? I did a bunch of things to give him the mobility back that he didn't have in the thorax. And in that case in particular, it was getting posterior thorax expansion. And the reason why that is because if I can expand the thorax, the scaps are going to be closer together, and then the humeri are going to orient more into horizontal adduction to fall back into midline. Thus, you would have a limitation in horizontal AB, right? Mm-hmm. So I pushed as much air as I possibly could into his upper back, and it went away.
It's amazing.
Like, unbelievable, like significant reductions. And wasn't getting it, you know, with moves. Like, it was mind-blowing. So it's like, I mean, I'm not that good. I can't change the properties of tissues over the course of 4 weeks. Like, you can't tell me that there was ligamentous remodeling in that.
Yeah.
So I think if there is a legit structural laxity, there's not much you can do about it. We're not there to make people prettier on the inside. Yeah. But what we can change is people's biases. So if that dude was biased towards being more concentric or short in his upper back, and I give him activities to change that, and that could potentially influence his biases in other areas of his body, namely his shoulder. So to me, I don't think of things in terms of laxity. It's simply you have a bias that's more towards concentric and more towards eccentric. It goes back to, like, let's simplify the options that you have available. Mm-hmm. And as the great philosopher Sylvester Stallone once said in Rocky IV, if I could change, you could change, we all can change. Yeah. So we can change our biases. We can change the amount of tension we have in our tissues. Humans are incredibly adaptable. We're bioplastic, as Lorimer Moseley would say. So to me, it's not an issue. And I definitely don't talk about that with clients because, if anything, that's going to instill fear avoidance. And I've seen it multiple times. And we don't need to do that. We need to uplift our people, and we need to instill independence. And that's really my mission. Is I don't want people dependent on me. I don't want them to, I want them to be able to live life the way they want to live it.
Absolutely. Yeah, I love that. How do you go about incorporating exercises with sort of a corrective approach within like a weight training? I don't know if you do this like within a weight training session, for example. Like, let's say you got power lifter and they've got some stuff they really need to work on, but they insist that they want to keep their squat high or their deadlift high. How do you go about programming these correctives within an actual program itself, if that's something that you do?
Yeah. I have a love-hate relationship with the term corrective exercise because I think anything could be corrective. So the way I think of it is, if, let's say this power lifter, and let's say they're very good, chances are they're probably a wide infrasternal angle, because you look at elite power lifters, they're big dudes and dudettes. So they have a bigger skeletal structure to move heavy ass weights. And that's going to lead to certain restrictions being present, especially if they're good at what they do, they're likely going to be restricted in all directions. So I simply have to think about how many, if the big three are non-negotiable because they want to do well in their sport, which I'm totally fine with, I get. then I have to find as many ways as possible that I can give them the stuff that they're not getting with the big three. So when we're talking about improving that person's movement capabilities, there's things in the warm-up that I give that are more low intensity, skill acquisition sort of things. So if, let's say we're working on them stretching out stuff on the front of their chest. Maybe I give them something like a dumbbell pullover, or I have them hang from a bar or something that's, a little bit more focused, slow paced, passive, or not passive, but isometric, minimal movement, where they're just focusing on getting into a particular position. So then you start with that, and then you just ramp things up accordingly, just as you would with a normal workout. Like even if you didn't do any of the stuff that we would do when you're training someone, you do something low intensity in the warm up. Maybe that's jogging and doing some other movements to loosen up the areas that need to be loosened up. And then you ramp the intensity up, and then you cool it down. You can apply the same thing to the stuff we're talking about. So those couple moves, that's part of the warm up. And then I need them to be able to demonstrate those positions at higher intensities. So maybe it's not in their big three, but maybe if they need to stretch out the front of their chest, I might be doing, unilateral pull downs as a potential exercise. Ab wheel rollout could be a potential exercise. I mean, just think of the positions I need to get them in order to stretch their chest. DB flies.
Yeah.
Right. With a breath at the end. Like you don't have to, it doesn't have to be these silly contrived breathing exercises for everything. You just need to think about, what are you trying to achieve, and what positions do I need to put the body in order to achieve that? And that could be, a relevant example. Another example, because this is something that powerlifters need to do is a true squat. And when I classify a squat, it's vertical displacement of the pelvis. That's what more Olympic lifters do. A powerlifting style squat, or a squatty squat, as people call it. Get out of here! Like we don't call it a pressy press or a pulley pull.
Right.
It's a squat. Sorry,
I love that. I love it.
Calm down, Zach. So squat, right? Vertical displacement. The big three moves and all that are dealing with more posterior displacement of the pelvis, or at least a back squat and a deadlift. Although research on the back squat may actually show, at least at low loads, that there is more vertical displacement, but that's for another day. So you want to do things to offset that, right? If you're doing things that are just pure hinge based or posterior displacement, I might give correctives that emphasize more vertical displacement. So perhaps they're doing their heavy loaded stuff. Maybe they're doing a back squat, but then their corrective is to do tempo Zercher squats with the heels elevated. And they're supersetting that with a half kneeling, or not maybe half, but maybe like a low sit cable chop to where the knees are higher than the hips, again, to get them into a position that they're normally not in. So same thing, right? You can still reinforce what you're trying to reinforce, and it doesn't have to be correctives. And in the traditional sense, and especially for people who are more well-trained or have a lot of muscle mass, the low intensity things that we would normally give are useful for building context of what you're trying to get them to do, but it might not be enough intensity to drive the changes you want.
I see.
I definitely find that the lower intensity stuff for people who are less trained can drive the change. At the gym that I work at, Elevate, I've been teaching a lot of my colleagues some of this stuff. And, we reopened 2 weeks ago, and we've had this, 3-month lull, and things are changing. And now we have everyone squatting on ramps.
Nice.
And doing more vertical displacement. And my buddy Francis, he goes, Zach, how do you educate people with this? And I was kind of going along a similar thing of some stuff of what we're talking about. He's like, well, yeah, everyone who's doing this, they're shaking tremendously with a very light amount of weight. And it's like, well, there you go.
Yeah.
Right? That's a perfect way to achieve buy-in. And these are not elite powerlifters, but they can be challenged by lighter weights, right? That may not always be the case with someone who's a bit more well-trained.
That makes perfect sense. I think that was a great explanation. And that's really an interesting thought you said about how the load with those compressed individuals, that might not be enough to stimulate those adaptations. I think that makes sense. And also goes back to what we said earlier about, like, you know, corrective exercise. Not a ton of people want to do that. So if we can give them something that's more along the lines of what they're looking for anyway, then it's two birds with one stone. You want to move into some Q&A now? I just realized it's almost been an hour. So time flies when you're having fun.
Yes, it does. Or as I say, time's fun when you're having flies.
Hey, there we go. Oh man, you're full of good ones. I love that.
I try, man. Let's do it. Let's get it.
So Josh asks, why do narrows get more ribcage expansion posteriorly if their pump handle is supposedly up?
So, well, if the pump handle was up, then they would actually be restricted posteriorly. So if we go back to, let me grab my grandson. So my grandson, right? If he's falling backwards, first strategy is to concentrically bias stuff on the front, which that would be, one example would be to concentrically bias stuff on the chest. So he packs all that stuff. That would depress the sternum, AKA down the pump handle. That's what he means by that. So this person would have a difficult time getting expansion in the front of the chest or stretching. So in that case, if I'm concentric on the front and I take a breath of air in, well, I'm not going to be able to push air there. So air has to go backwards. So you get posterior expansion. Now, if the pump handle is up in that individual, right, it shouldn't be. That should be down. The way that happened was because of another layer of compensation. And somehow, some way, some shape or form, they've concentrically biased the backside of the body. That's caused the pump handle to pseudo become up, right? It's not really, because you still have that layer of compensation to deal with. But what it's done is it's changed the shape of the thorax enough that it may allow them to actually clear some measures of extension, adduction, and IR. So that would be the relationship of the upper thorax in theory with someone who's narrow.
That makes sense. The wording was just okay. All right. So Sam asks, how much air is going into the posterior rib cage on a 90-degree reach? It seems like there would be more air going into the back than the front because of the shortened position of the pec. So I guess that depends anyway, it's a question for you.
So I don't know specific amounts. That's likely individualized. But here's what you have to think about. The resting position of the scapula in normal subjects is about 41 degrees of internal rotation. And this is from a study by Paula Ludwig. She's like the OG when it comes to scapulohumeral research. As you move up into progressive shoulder flexion, there's going to be more scapular external rotation, meaning that the medial border of the scapula is going to be more approximated to the rib cage. All right, the IR, it's going to be further away. So then we have to ask ourselves, what muscles, or where are the muscles located that drive scapular internal versus external rotation? Well, when we're talking about the posterior thorax, the big external rotators of the scap are overlaying the posterior thorax. So you're looking at your traps, you're looking at rhomboids. And so if those have more concentric bias and they're toned up, they're going to restrict the amount of air that's going back there because those muscles have to elongate in order for that to happen. Now, it just so happens that I start to pick up scapular external rotation from about 60 to 120 degrees of shoulder flexion. So there's going to actually be reduced air going posteriorly in comparison to outside of those ranges. So 0 to 60 and 120 to 180 ought to get more posterior expansion, albeit in different regions of the rib cage. So now does that mean that you can't get air back there? No, you're absolutely going to get some. We aren't talking on-off switches. We're talking relative and gradients and amounts. But because of the position of scapular external rotation that's driven at 90 degrees of shoulder flexion, is going to be less so than those extremes. And you'll especially notice this on people who are extremely concentric in their upper back. Like they have super flat backs, and despite their best efforts to reach forward in quadruped, you can't get the scapula to be flush against the rib cage. Y'all know who I'm talking about. Connor, you're seeing like, oh yeah, I got this person right here. You can try that move till you're blue in the face, until maybe they're blue in the face, but they're going to have a really hard time getting air into the upper back. And the reason why that is because they're so concentric already. And then you put them in a position where those tissues become even more concentric. And thus you're incredibly restricted to get air back there. So that's why at 90 degrees of shoulder flexion, you get less air going posteriorly and more air anteriorly. And the reason why that is too, why does air go anterior? Well, if I'm more blocked off in the back and I breathe in, it's got to go somewhere. So it's going to shoot in the front.
Yeah.
Assuming you don't have a ton of pec.
Yeah. I think thank you for saying that, because I think it makes sense, like at least from where this guy's coming from with this question, because if you were to get your ribs back, it would be like, yeah, okay. So you could see how that would technically be opened up, but because of that concentric activity, that's not actually the case. So thank you for answering that. That was really well said. Amy asks, L-shaped headstands. Who would you give that to? How do you teach it? And how would you progress it? So I guess that's your inversion type of work.
Yeah. L-shaped headstand. Usually is someone who's more physically active, first off. So like, when I worked in Page, we had a lot of people who were Gen Pop and not very active population. The high schoolers got headstands and that was about it. So who do I give that to? I'll give an L headstand to someone who is restricted in multiple directions in the upper parts of the thorax and the cervical spine. And the reason why that is because if I invert someone, I do this ad nauseum. So I got my clean canteen water bottle here. Okay, let's assume this is a person. Yep. Bottom part of the water bottle is the pelvis. The upper part would be like, upper thorax, cervical spine, and there's water in here. Trust me, there is. If I tip this upside down, it didn't leak, thank God. There's going to be more water now in the top part of the water bottle. So what does that mean for our peeps? Well, when I invert someone, they're going to be able to fill the upper part of their body much more easily than they will the bottom part because of the effects of gravity. From a practical aspect, this would be inflation of the lungs. So when you fill your lungs, they fill from the bottom up. If I invert myself, they'll now fill from the top down. So that would be one thing. So anyone who's restricted in multiple directions in the upper parts of the thorax, that's a great candidate for a headstand variation. Now, who needs an L headstand versus, let's say, like a knee to chest headstand? Because I give those as well. So based on, now I'll grab my son for this one. We're talking about a difference between 90 degrees of hip flexion versus 120 degrees of hip flexion, like an upside down squat. We have to think about what's going on that's characteristically different in the pelvis in both of those ranges. At 90 to 100 degrees of hip flexion, your posterior rotators in the hip have the largest bias towards driving internal rotation at the femurs. Internal rotation is going to drive more nutation at the sacrum. So if you have someone who is more limited in extension, adduction, and internal rotation, an L headstand variation would be desirable. And if they're narrow, they should be relatively cleared at flexion, abduction, ER before using the L position. With a knee to chest, right? As I go knee to chest, I now have relative motion of the pelvis driving the motion. There's re-external rotation at the femurs. That's going to drive more counter-nutation at the sacrum. So if someone's more limited in flexion, abduction, ER, then you might consider doing a knee to chest headstand. So that's when you would use that. And they're great moves. You just got to play around with which variation goes best for them.
That makes a lot of sense. Phil asks, LASIK thoughts. And I actually know where he's coming from with this. So with people that, let's say they have a good amount of dysfunction going on, and They've got some eye vision stuff going on too, and they're thinking about improving their vision through LASIK. Do you think that that would be a desirable strategy for someone, even if they're not back to, I don't know, quote unquote, a more neutral posture?
That's a tough one. And it's, unfortunately I've been a little bit out of this area for a bit. My initial thoughts would be there's a lot of skills related to vision that go beyond just sight. So one area that's intriguing to me, I don't know much about it, so I can't really comment a whole lot on it, is vision therapy. Because I think there's like 17 other skills that your eyes can do besides sight or something crazy. So yeah, don't like, fact check me on that, please. So I think it behooves most people to make sure that they have those other skills in place and have an appropriate amount of movement options in the neck and whatnot before doing LASIK, because that's a little bit more of a permanent thing. Now, if you had LASIK already, does that mean you're screwed up pooch and, you're going to have some issues? Well, it depends on if the LASIK surgery was botched or not. I had a guy who I eval'd recently. Oh my God, this poor guy. He actually had really good vision, and he was like, "Oh, I'll get LASIK. Why not?" Because he was, he's getting like, turning about 45, or and you know what happens when you turn 45. I remember Bill when he was, he had to always do the look away sort of thing when he was reading.
Yeah.
And so we gave him shit for that. But he didn't want to have to deal with that, so he decided to get LASIK, and it was botched.
Oh my God.
So they screwed it up, and the only way he could see was if he had some type of monovision correction in his eyes. And for those of you who don't know what monovision is, one eye becomes more biased to seeing up close, the other eye is biased towards more far. And guess what he saw me for? He saw me for neck pain. That's been going on for 2 years, and thought it was because of an accident, but he had LASIK around the same time. And so when he would get his phone out, he would have to do like this weird thing. And I'm like, man, are you doing that because your neck hurts? And it was so he could see. So if you have a botched surgery, LASIK is not desirable. But if you've had LASIK, does that mean it's a death sentence? I don't think so. I think, and this is not just true of vision stuff, but also dental and, all of these things. Like, the human body is very adaptable and can compensate well. And we can survive so much.
That's a great point.
I mean, think about how in the heck do people who have had amputations exist, right? Like, they're doing incredible things. They're doing absolutely incredible things. So to say that some type of structural change like this or having a bad bite is going to just ruin that person, I think is complete BS. Like, there's ways that we can compensate around these things in order to be effective. And the song and dance is the same. It's like, I challenge those people. If you had, let's say you had LASIK, have you maximized all your movement capabilities throughout the rest of your body? Cool. Have you done things to improve some of the other things that we would need to do from a health perspective? Are you sleeping well? Are you, not living in front of a screen? Are you eating healthy, whatever the hell that means, so on and so forth? Like, maximize all of these other qualities first. And then if you're still having issues, then maybe this does matter. But I think your first line of defense is probably to go to vision therapy. And it's something I want to do for myself personally, from a learning perspective, one, but two, I can't cross my eyes. So there's something going on here. Like, it's funny when I try.
Is that a skill we should have? Should everyone be able to do that?
Yeah, like, you should be able to be able to have them cross. And there's a ton of exercises you can try online, but I would like to have someone who's skilled in the arts teach me. So, we have skills in the gym, squatting, hinging, push, pull, that we want our people to do. There's skills you should be able to do with your eyes. Make sure you can do them. And then if you can't do them, go see a VT and, have the pros take a look at you.
Makes a lot of sense. Well, Zach, I think that's all we had for you. Thanks for coming on, man. This was a lot of fun. And it's always good to hear from someone who's like experienced and has been there and is really trying to put the good word out. So thank you, man.
Connor, I appreciate you having me. Keep it real, but not to the extent where things go wrong. All right.
Sounds good.